Good afternoon. I see folks joining. Thanks so much for being here. We'll give folks just a couple of seconds to get going here. Thanks so much for joining us. This is our third webinar in a series of 5, and we'll talk about that here in just a second. My name is Dr. Ben Miller. I'm the Chief Strategy Officer for Wellbeing Trust. We are a national foundation focused on advancing the mental, social, and spiritual health of the nation. And again, it's my honor to be able to serve as today's moderator for today's session on rethinking workforce. If you're new to workforce, this is going to totally rock your world because this is a very different thing we're doing today. And we hope that it actually opens up some ideas that folks have on what workforce means and what some of the public policy decisions we make, how we might need to rethink even our public policy around workforce. This briefing is the third of 5 sessions that were organized by the National Mental Health and Suicide Prevention Response to COVID-19, or what we call the National Response. This was in partnership with Wellbeing Trust, the Kennedy Forum, Inseparable, American Psychological Association, the National Alliance of Mental Illness, and the Education Development Center. For those not familiar, the National Response is an initiative of the Action Alliance, which represents a public-private partnership that works to create meaningful change in mental health and suicide prevention. There's a special attention in the National Response to what happened during and after COVID-19. The National Response was led by former Congressman Patrick Kennedy and the NIMH Director, Dr. Josh Gordon, as well as a steering committee comprised of senior leaders from the field. Our opening session of this series really laid the groundwork for how our country can embrace more comprehensive response to mental health and suicide prevention during and after COVID-19. And if you're interested in learning more about the National Response, you can go to the website nationalmentalhealthresponse.org, which includes the 6 priority areas. So last week, we talked to you about our nation's crisis response, specifically on how mental health should not be treated as a crime. It was a really enlightening discussion on all the problems we face as a nation and how we can restructure a response to individuals in a mental health crisis, an essential need for sure. Undergirding all the priorities outlined in the National Mental Health Response is workforce, which is our topic for today. And as many of you are probably thinking, yeah, I know, Miller, we've got a workforce problem, and you wouldn't be wrong. However, as we hope to lay out today, most of the solutions we pursue in public policy are trying to answer the wrong question. How many clinicians do we have and where are they located? The answers to these questions often leave us just wanting more because the answers usually are the same. We need more clinicians and we need them everywhere, especially in the places that they're not, places like rural areas. However, and I really think that this is key for today, there's a different way to think about workforce, one that takes some of the burden off our traditional clinical systems to allow for more of a community-forward approach to care, to create the conditions to allow for each of us to take on more responsibilities for mental health, to become more creative in how we tackle the seemingly never-ending challenges that we each face. I firmly believe as we're asking the wrong questions about workforce, and that is an imperative that we get it right, and we think about a new strategy for addressing our community's needs. As I'm fond of saying, we need a new workforce that emerges in community, by community, and for community. This approach, if we embrace it, helps solve some of our biggest problems. We know that 1/3 of the country lives in a mental health professional shortage area. And despite mental health and mental illness being everywhere and costing us, we still don't have the workforce in the places that people actually are. Recently, Dr. Anita Burgos and I published a paper for the Scattergood Foundation that laid out a framework to begin to think about this approach to our workforce. This framework calls for 3 major shifts in the healthcare workforce to address the increasing demand for mental health and addiction services and, as I've already mentioned, the limited capacity. Solely relying on our licensed clinical workforce will not allow our communities to get ahead of the problem and more proactively address issues of mental health. And as our healthcare system often forces us to wait until there is a problem, as many of you know and maybe have experienced, a diagnosis must be given. For many of us, help comes too late. So broadening how we think about our workforce allows for more timely interventions in the places that people are showing up with mental health needs. This is actually the work that Wellbeing Trust and others are doing alongside our friend at Harvard that you'll hear from in just a second. So that brings us to today and our amazing all-star group of individuals who are gonna walk us through some of the innovative ways we can think about workforce. So let me do quick introductions of all our panelists. We're gonna start with Kelly Davis. Kelly is one of the most passionate and insightful mental health advocates I've ever met. Her lived experiences with mental health and trauma are a driving force of this passion for helping transform how we can support individuals and change systems and services. She currently works at Mental Health America, where she helps lead the peer advocacy supports and services. She's also on the Wellbeing Trust Advisory Board, so I'm a little bit impartial there. Thank you, Kelly. Kelly, so glad to have you with us. She's going to kick us off with her story and the amazing work she's doing to advance peer support services. After Kelly, we're going to go to Rachel Nussum. We have Rachel, who's the Vice President for Federal and State Health Policy Initiatives at the Commonwealth Fund. Rachel is the person you want to get a call from when there's a policy event. She works closely with policymakers at both the state and federal level and is responsible for developing and implementing the Commonwealth Fund's national policy strategy for improving health system performance. Rachel has done it all in policy, from being a staffer on the HELP committee to serving governors in amazing places like Colorado. She's on the faculty of Georgetown University's Graduate School of Nursing and Health Professions and on the board of the Winston Health Policy Fellowship. Rachel's going to provide an overview of a recent Commonwealth Fund report on solutions for improving mental health services and lessons learned from around the globe. And then next we have our Harvard tag team. We've got John Naslund. John is an instructor in global mental health and social medicine at Harvard Medical School. His expertise in mental health epidemiology, implementation science, social disparities research, and digital mental health. He is a prolific academic with over 65 peer-reviewed publications and has contributed to projects all over the world. He has a long-standing history of working alongside individuals living with serious mental illness and community mental health providers advocating for change. Along with John, we've also got Shekhar Saxena, who is the professor of practice of global mental health at the Department of Global Health and Population at the Harvard T.H. Chan School of Public Health. Shekhar, we got to make that into an acronym, my friend. That's a very long title there for you. But Shekhar is a psychiatrist by training. He served in the World Health Organization since 1998, including an 8-year stint as the director of the Department of Mental Health and Substance Abuse at WHO. Shekhar is an international treasure. He's written more articles on mental health than some of us will ever read in our lifetime, and he's a great example of a humble leader who makes a difference everywhere he goes. So John and Shekhar are going to tell you about the amazing work of Empower and how to take task sharing models, like I described just a minute ago, how they can and should happen everywhere. And to close us out, we've got Priscilla Gutierrez, who is who earned her law degree from UC Irvine and is a passionate mental health writer and speaker with a very impressive legal and sociological background. Her ability to connect the healing power of stories to change, especially in Black and Brown communities, is inspiring. She leads by example and understands and works to fix complex issues like how culture and racism affect access to mental health care. Today, she'll be speaking to us about the Confess Project, where she's the content engagement consultant. I'm so excited for her to tell you about the amazing work Confess is doing for mental health, some of the most innovative and meaningful work bringing mental health training to Black barbers and barbershops. So as a quick reminder, a recording will be sent out after the webinar. You can type in questions into the Q&A box at any time. We'll answer it, if time permitting, as we get to them. So, all right, Kelly, let's get going with you and get us started right.
Unmute myself. Thanks so much, Ben, and thank you, everyone. I'm so incredibly grateful to be here and to be with some phenomenal presenters. So I'm going to start, as Ben mentioned, to share a little bit about my personal story, how it informed the things that I'm working on, and how I believe that peer support and peer specialists are a critical piece in how we promote and address mental health now and moving forward. So my story, as long as I can remember, as early as I can remember, I felt like there was something different about me than the people around me. It often felt like my feelings were physically too big for my body, and I didn't have any language to explain what was happening, and I didn't see it happening for anybody else. And by the time I was 10 years old, I had my first suicide attempt. And that really launched me into the world of mental health services. So from the time I was 10 moving forward, my life was increasingly dominated by things like inpatient services, outpatient services, intensive outpatient services, many different psych meds, and lots of doctors and appointments. And this was an experience that I was really dealing with by myself and felt that I had to keep secret from the people around me. And by the time that I was 19, I was in college and I was on the verge of dropping out of school. I was diagnosed with bipolar disorder. And I was essentially told that you have a serious mental illness. People like you don't do well. You should go home and try not to stress yourself out too much. And when I heard that, I thought back to something that I had seen a couple years ago on a website called Stumble Upon, which you just pressed a button and it showed you random content. And there was a photo of an elephant, and it talks about how when elephants are in captivity, they're used, when they're babies, they use chains to help them from running away. And by the time the elephant is fully grown, they could easily break free, but they don't. And something clicked inside me that the way that I had access to mental health services and the way that they were delivered to me and what I was told about myself, maybe none of it was true. And I had to try something so that I didn't have the life that was being presented to me by the clinicians and the people around me. And during that time, I found the peer support movement. And these are people with lived experience who shared with me that many of the things that they were told about themselves were also wrong. And there was more to their lives than reducing their PHQ-9 scores. And there were all of these things that you could do to support yourself and one another in community. And through that process, I really began my own recovery and well-being, and my life was really given back to me by the movement and the work of people with lived experience. And after graduating college, I continued to work in mental health advocacy. I was an organizer on my campus. And what I found was that people were advocating for the same services that I had and the same design of a system that I had. And I'm privileged enough that I had access to everything, and it was wrong. And I believe that we need to rethink the starting point, the center point of how we support well-being among young people and all people. Because one meeting, if you're lucky, an hour a week in a dark room and maybe 15 minutes every 3 months with a psychiatrist is not enough to create the well-being and lives that really matter to people. And the movement of peer support really shares that we heal in community. And not just that. Many people, in my experience, people like me who are diagnosed with SMI often have real harm inflicted upon us by mental health services. And many folks, one of the young people who I work with is a young adult and said the only time that I had mental health resources was when a social worker came and tried to take me from my family. So not only has there been real harm and there's real barriers to getting people connected to resources, there's all of this other parts of life where people shouldn't have to hide their well-being and people can learn to support one another. And I think the really old and outdated framework where we make people build their lives around mental health systems instead of building mental health around people's lives is not only outcome-wise not what we need to do, but it is financially impossible. And with COVID and the increase in need that we're seeing, it is timeliness also impossible. So my work at MHA really focuses on expanding access to the peer support workforce. So peer support specialists are people with lived experience of mental health conditions or substance use disorders who receive specialized training to support other people with lived experience in their recovery and well-being. So yes, peers help people navigate resources. They show up on mobile crisis teams, they show up in inpatient psychiatric units and emergency departments, all of the places where people look for support and are met by a completely disorganized and piecemeal system of resources that are the only place we really refer people to when we know they're in distress. But the core of peer support is this shared experience of hope and belief that things can get better, and an understanding that people are more than a clinical diagnosis and that everybody benefits from resources to help them promote their well-being and to help them feel empowered, whether that means accessing clinical services or it means taking steps and finding resources like yoga or like church or arts that really help them heal and transform. Peers are now available certified in 49 states, while California is in the process of developing its certification, but really growing across the country. And in addition to kind of having peers embedded in all of these clinical models, whether that's an increase in peer support in primary care, on first episode psychosis teams, on crisis response teams, peer-run respites, which are alternatives to hospitalization for people with psychiatric diagnosis. Hospitalization and emergency department usage are often traumatic and not really therapeutic. So providing a place where people can go by people who understand is really healing, especially at a time where we're seeing increasing thoughts of suicide and mental health crises among people. But I think one of the key overlaps between the values of peer support and this movement towards rethinking the workforce is this idea that that people heal in community, and we want people to have access to the resources they need. But like I said, we don't want people to build their lives around resources. And peer support, yes, it meets people where they are. It meets people in clinical care. It gets people to connected to the more comprehensive things that are important to them, like employment, like education, like community. But peer support is not just part of integrated settings or healthcare settings. Peer-run organizations and the history of peer support that really comes out of the 1960s with deinstitutionalization, where people who faced extreme abuse at the hands of mental health services realized that they were let back into the community with virtually no resources to support themselves, and they built their own alternatives to systems. And the peer support world is really also largely driven by community-based organizations. So people can transition away from, I'm dependent or my whole life is mental health services, to having these communities of well-being where they support one another and they support themselves. And beyond just the adult services, peer support is really important no matter where you go. And we're seeing peer support increasingly on college campuses, in high schools, with this humanness and this key understanding that when people are in distress and when people are in crisis and when people just need somebody to talk to, we should honor their humanity and provide resources for them to connect with and support one another. And there's many, many things that clinicians do and that traditional mental health service providers do that you do not need 7 years of school to be able to do. But we really need to be giving resources, yes, to certified peer specialists and enhancing the workforce, but also to all people, especially people with lived experience, because they're the ones who are going to be there for people when they want to talk about suicide and are afraid, and can say, I've been there and it gets better. And I'm going to connect with you, not only because I was trained in this way, but because I was there and I can give you hope. And I think in this reimagining of the mental health workforce, we really need to center not just the patient, but the humanness of people and the ability for them to support one another and themselves wherever they are. So with that, I'm at my time and I will pass it back to Ben.
Wow, Kelly, that was amazing. You said something really profound that I actually think is a perfect segue to Rachel. We heal in community. We heal in community. There's something amazingly simple and yet complex about that sentiment. And Rachel, I know you're going to talk to us a little bit about this, but it seems like when we look at examples from across the world, that community healing approach is something that's embraced a little bit more than maybe we've gone in the United States. So I'd love for you just to kind of educate us a little bit about some of the stuff that you all have been working on in this space.
Great. Thanks so much, Ben. Thanks for having us. Thank you, Kelly, for sharing your really powerful story. It's very difficult to follow, but I do think, as Ben indicated, the data, and when we look at some successful models from other countries, many of the components that Kelly spoke about of being so essential we can find them very easily. So just very quickly, the Commonwealth Fund is a private foundation. We're over 100 years old. We're focused on ensuring equitable access to high quality healthcare for all Americans. I really need to acknowledge my colleagues, Reggie Williams, who runs our international program, as well as Martha Hostetter and Sarah Klein, who authored the piece that many of my points will be drawn from today. So go ahead to the next slide, please. So one of the foundational activities that the Commonwealth Fund's been engaged in for almost the entire 100+ years that we've been in existence is this activity around looking at international models of care and delivery, and really looking for innovations and delivery insights that might be applicable and transferable to the United States. And mental health has been an issue that we've really been focused on for the last couple of years specifically. So let's take a look at what we see when we compare ourselves to our peer countries. As you can see here on the slide, Americans are more likely than their peers in other high-income countries to report mental health concerns. And during the pandemic, these findings were even more acute. And we saw more of a gap even between the United States and other countries in terms of how our mental health responded to the COVID-19 pandemic. We also know from the same analysis that economic well-being and mental health are very much connected. We know 56% of all adults who reported that they had negative economic consequences due to the pandemic also reported mental health issues as well, and the need for care and support, which really goes to support, I think, Kelly's points that it really is beyond just the clinical, but really the need to really understand all of the struggles an individual may be going through. Next slide. We know also, just as every other aspect of the healthcare system, the mental health effects of the pandemic were not evenly distributed or distributed equally. We see incredible inequities by race and also by income. We can talk more about this if folks would like to. Next slide. And I know that today we're really going above and beyond our traditional counting of mental health professionals, psychiatrists, nurses, psychologists, social workers. But I thought it was really important just to get a foundational perspective of where we stand. So you can see this is where the United States was. The state is a couple years old, but this is where we stand in terms of our supply of mental health providers, that typical mental health provider that we just talked about. And again, keeping in mind that we do have much more in the way of demand for these services than we see in other countries. Next slide. One of the ways that we've been working around this with the help of Ben, but also so many others, is this idea of integrating behavioral health into primary care practices. We are doing a little bit better on this indicator, but as you see, we're still down in the middle of the pack. And the other thing that's really important to remember, one of the other components that we see when we compare the United States to our international peers is our chronic underfunding of primary care as well as social supports as well. So we have fewer mental health providers. It is less likely that mental health or that primary care practices have a mental health provider embedded in their practice, and we're chronically underfunding primary care and the social support systems that we're seeing in other countries that are kind of wrapping around. So when we take that all together, it really emphasizes the need to have the conversations such as the ones we're having today about how to really get creative to address connecting folks with the care that they need. Go ahead, next slide. Again, this slide shows you that the United States, this is primary care practices and their response when asked, how prepared do you feel to respond to the mental health needs in your practice? And this is, I think, pretty consistent and pretty explainable when we reflect on the fact that it is not as likely for practices in the US to have an embedded mental health professional or adequate resources in their practice. Next slide. So this is the fun part. This is what Ben really asked me to do. We needed to get some of that stuff out of the way before we did it. So the piece that the Commonwealth Fund did really looked to our international peers and with the question, what is working in other countries? And is any of it something that we could try here? And we really see these 4 buckets of innovations that when we look across from Australia to Zimbabwe to Pakistan, Norway, we really see kind of these 4 big trends. And I'm only going to talk about a few of them. We can come back to some of the others in the question and answers. This first one around treating mild to moderate symptoms is this idea of how do you pull out the high volume, low intensity services and get really creative about how you connect folks to those types of services. This is in fact where some of the models that Kelly was talking about are really, really helpful with, 1 in 14 Americans reporting symptoms of anxiety, around 1 in 20 reporting symptoms of depression. These are really high volume situations, some of which are low intensity enough that they could be treated with a lower level or a more creative approach on health professionals. And we'll talk about some of the examples that we're seeing in other countries. The other thing, as I mentioned, this integrating of physical and mental health care. One example is in the Netherlands. They decided in 2016 that it was critical for their patients to all have access to mental health services. And they invested in their GPs, or their general practice infrastructure. And they now have 90% of their practices that have a trained mental health provider, not always a physician or a psychiatrist or a social worker, but someone who's trained in identifying and referring and providing that immediate support. 90% of their primary care practices have access to that in the Netherlands. Next slide. I love this slide. This really addresses this fourth bucket of addressing the whole person, the social, emotional, and the physical. As I mentioned before, one of the things that we know about the US is that we chronically underfund primary care, but we also chronically underfund those social support services, housing, food security, job security, poverty reduction, childcare. When we look at our peer countries, there's just more in the way of social and emotional supports. And these three programs that I put here really kind of capture what you can do when you engage your community and engage the community and train them and really equip them to provide very low tech, very inexpensive, we call it a frugal innovation, outreach to the community members that are in need of care. So you see an example here of the Thrive Gulu program in northern Uganda that we can talk more about. Up on the left, you see, this is Dixon Chabananda and the Grandmothers of Zimbabwe. This is really where the Friendship Bench took hold. He was the originator of the Friendship Bench, which for folks with kids, it's in almost every community. There might even be one at your school, but it is really taken off across the United States already. And down here, you see a picture of the peer support and resources for young adults at Headspace in Australia. And this is a really cool model where it's a one-stop shop for young adults to come and connect with their peers, but also get job-related resources, networking resources. There's someone there checking in on how are you doing managing your stress? How are you doing with the pressures and other things you have going on? So just three really quick models of very low-cost ways that countries have explored, really investing in their community, training them to provide that hands-on care. Next slide. So just to wrap up, as we look across kind of international models, we know that they have succeeded in ways that the US has not, because they've done some key things. They've set a national strategy to address mental health. They've devoted a dedicated budget and committed to transparency around the effectiveness of their interventions and their outcomes as part of their mental health efforts. This is nationwide. This is not targeted populations or targeted systems. This is as a nation, this is what they've done. We know that successful care models are convenient, customizable, and scalable to meet the need of the patient and the community, not the healthcare system that it's adjacent to. Given the shortages and the shortcomings that we've talked about, a rethinking of the workforce will be critical to achieve the goals of delivering effective mental health treatments. We know that the COVID-19 pandemic and the new administration and the recognition that untreated mental health conditions contribute to higher healthcare costs and lower productivity present a policy window to think big on improving access to mental health services. And that's really where you all come in. Finally, interventions should be assessed by whether they reduce inequities in access and outcomes or exacerbate them. This is especially true for digital tools and applications, which we didn't talk a lot about today, but there's a lot of them out there. And there's a lot of feelings about them, but really critical to keep in mind that we need to be asking ourselves, are these reducing disparities or are they exacerbating it? And asking that as an ongoing basis, because things do shift. And then finally, just a reminder that mental health does equal public health, and our public health, if we've seen nothing else in 2020, is that public health really equates to economic health and viability. So we have a policy window, we can talk more about that, but the time to address this is really now. So thanks so much, Ben.
Rachel, that was amazing. And we'll put in the sidebar, make sure that it comes out with the resources, the wonderful resource that you described and worked from. So thank you for that, Rachel, really great information. Okay, John, I will turn it over to you and let you kick it off for the Harvard team.
Great, thanks so much, Ben. Just going to skip ahead actually, because I'm got some content here that I think has mostly been covered. Just really emphasizing that mental disorders are a leading cause of disability in both the United States and worldwide. And just building on what the last two speakers covered, it's there's really been, I think, an incredible paradigm shift in kind of thinking how we can approach the treatment of mental illnesses in community settings. And this has been, really building on the last 2 decades of research around this concept of task sharing, which I'll talk a bit about today. And what we know is that community providers, whether they're lay providers or other non-specialist providers, essentially anyone at the community level who does not have specialized training in delivery of mental health care, such as a psychologist or a psychiatrist, can be trained to deliver brief psychological treatments, and they can do it very well. And as the last speaker mentioned, that much of the evidence from lower income settings has shown that these programs are actually highly effective. The issue is not so much that these programs don't work. Actually, it's the contrary. We have very good evidence they work. We're just not getting them into practice. And that is a major barrier, and it's a major focus of my research, both in the United States and globally. So I'll walk through a few examples. Next slide, please. So as mentioned, it's not so much a lack of knowledge. We actually have really, really good evidence. And I'm going to go through some of the key studies in this area. Next, please. So really, we actually have evidence that not only do these programs work in terms of achieving good outcomes, retaining outcomes, but they're actually very good cost effectiveness studies as well. Next slide, please, or next. Yeah, so this is the Friendship Bench, which we just heard a little bit about, developed in Zimbabwe. Again, one of the programs that demonstrated effectiveness in terms of treatment of common mental disorders in primary care settings, also a form of task sharing. Next, please. We have the Thinking Healthy program. This was used in Pakistan in a conflict-affected area. Again, another example of a task sharing model, training community health workers. Next, please. We've seen effectiveness. This is a program led by Sangath, which is a leading research organization in India. And they developed this program around counseling for alcohol problems. This, again, very robust evidence that you can train lay providers to deliver effective care in primary care settings. Next, please. This is the Healthy Activity Program. It's a program that has shown effectiveness for treating depression, and one that I'll talk a little bit more about in a minute, but also developed and pioneered by Vikram Patel and others through Sangath, an organization also in India. Next, please. So there's been summaries of this evidence. So basically looking at meta-analyses, summarizing this from many of the different low and middle income countries where these programs have been developed and piloted, showing that even when you combine the evidence, that they actually show very robust outcomes that are sustained across different settings. Next, please. These programs also work for various underserved populations. So these are just, really showing that there's a robust literature. Just kind of really hammering this point that we have very good evidence that these programs are effective and work in many different settings. Next, please. This one here, again, summarizing it in a meta-analysis. This is summarizing all the studies from many of the different countries, low and middle income countries. And what I think is really important here is that even though many of these treatments initially originated actually in higher income settings, such as the United States or the UK, the delivery of psychological treatments, when adapted for specific cultural groups and when carefully tailored to the local context, are as effective, and even in some cases more effective in these different settings when they're carefully adapted. And that's what one of the key findings in this meta-analysis demonstrated. Next, please. And then I think just to highlight this study here, this was from the World Health Organization, just emphasizing that actually using these programs is not only are they effective, but there actually would be tremendous return on investment. Next, please. And last year, this umbrella review, I think this is kind of just summarizing all of those last studies. This looked at 123 studies from 35 different countries, basically with the same conclusions that I presented on the last slide. This is just, I think, nicely summarized last year, but basically these work very well. So we know that, and they work for a range of mental disorders across a range of settings. So that leads us to our next problem, that they're not getting implemented into practice. Next slide, please. So again, this is the major issue about just the lack of coverage for these programs. And this is where I'll lead to our next, the sort of where our work is heading at the moment. So next, please. And this is really a need to think beyond conventional approaches and to think of innovative ways to get these types of programs that we know work well and finding ways to get this evidence into practice. Next, please. So this is a program that we're leading here at Harvard Medical School, and very pleased to be working with the Wellbeing Trust on this project as well. It's called Empower, and essentially leveraging technology, which I know was mentioned, just mentioned the role of technology as a potential tool for advancing access to care, but thinking about how we can use technology as a way to support community providers and other individuals in learning, mastering, and delivering these treatments. So all of that evidence basically from the last slides, how can we leverage technology to create a workforce to effectively deliver those treatments and to ensure that they're receiving the supervision and support needed for ongoing quality assurance. Next slide, please. So the goal of our project is really to address these three major barriers. We've grouped these three major implementation concerns. One's the content. So we know these treatments work well. The content of these programs is just not getting to people who can actually use it in practice. The supply issue, there's just not enough people actually trained to use these different programs. And then also the other issue with the content is that the content is pretty academic. And I'll talk about that in just a second. A lot of it is developed by clinicians and researchers, and they're not really in the most approachable formats. So it's a concern for actually disseminating these programs. And then again, I mentioned the supply issue, just training individuals to actually deliver them. And then the last kind of really important piece is the quality. So if someone's trained to do this, and we know they can do it well, how can we support them to make sure that they can deliver these programs effectively over time, and that they themselves aren't burned out? Because we know that actually delivering mental health services, especially when we're thinking of community providers who are living in the same communities who may be affected by the same challenges as their patients, how do we help them and support them over time so that they can continue to deliver quality care without facing additional stressors or burnout themselves? Next, please. So the work that we're doing, this is Empower, just an overview of how we're envisioning this work. So Vikram Patel here at Harvard Medical School, along with our team, including Shekhar, who will speak after me, are working on this project called Empower. And essentially this is following the entire continuum, going from initial training and supporting the health workers, assuring development of competencies and the skills needed to effectively deliver care, all the way through to supervision and ongoing support, and then integrating this into the system. So how do we actually go from getting providers trained and ensuring competency to making sure that the care that they're delivering is actually part of a bigger system, so that patients aren't lost to follow-up or that they're not being tracked and outcomes aren't being measured. Next, please. So as I mentioned, we have these highly academic manuals. I mentioned the Healthy Activity Program earlier. So essentially, this is a behavioral activation treatment. So brief behavioral activation programs were initially developed in the US or UK and have demonstrated high effectiveness in treating depression in primary care settings. This version was further simplified and adapted for the context in India, in one setting in Goa, India. And basically, it's still a pretty academic model. We have these fairly academic manuals. And how do you actually take sort of this paper-based manual and then make it approachable for community health workers? Next slide, please. So this is an ongoing project. It's funded by the National Institute of Mental Health. And this is really serving as some of the foundational research for the Empower program that I just mentioned. It's basically, how do you take, as I mentioned, these paper-based manuals and get them onto a smartphone app that's both interesting, engaging, and easily accessible in rural settings where connectivity issues are present, where digital literacy, there's low digital literacy or low access to digital tools. How do you support individuals in settings like this to access this program from a smartphone app and ensure that they can still gain the necessary skills and competencies to deliver this program effectively in primary care settings? So this is an ongoing project. We have 340 health workers currently enrolled in this study. And they're completing the training, and they've worked with us to carefully develop the program. And this is in a rural setting in Madhya Pradesh, India. Next slide, please. So this is just to give a sense of what the program looks like. So essentially taking the content, and I'm happy to talk about this more to follow up afterwards, but using a combination of video-based content as well as images and graphics and ensuring that the language is carefully tailored to the local context and culture and setting. And this involved a systematic process of carefully working and engaging community health workers. Next slide. Have this process mapped here. I won't go into too much detail about how it worked, except that this process was informed by established frameworks, and then also thinking really of a design framework to make sure that health workers were at the table with us in the development of the content, working closely with our team in Bhopal, India, making sure that we were not developing something that would not be relevant and approachable, but also at the same time consulting experts. So the actual individuals who develop behavioral activation and the healthy activity program, making sure that we weren't deviating from the content that we know is necessary in order to achieve the outcomes that I mentioned earlier, the effectiveness outcomes of these programs. Next slide, please. So this leads to our key priorities and work in the US, essentially learning from this initial project in India, to do a very similar work, adapting it for frontline providers in the US. So we're currently in collaboration with the Meadows Mental Health Policy Institute, with funding from the Sergo Foundation, to take the same treatment manuals, behavioral activation, and to translate that to a easily approachable digital format for training frontline health workers in Texas. So that's where we're working right now, and also in collaboration with Wellbeing Trust to really think about how to move this past simply providers working within health systems and thinking more broadly who in the community could be trained, who could acquire the skills and competencies needed to really make these types of programs more widely available, to improve reach, access to diverse communities and other settings. Next slide, please. And this is my last slide, I promise. And really just highlighting this exciting partnership with the Wellbeing Trust. Really thrilled to be engaging in this work, but to think carefully. So we have the evidence. We know now that we can digitize this work. We can digitize it to a format that's approachable and interesting for health workers in different settings. But now thinking about how can we move from there? And then back to that same problem I mentioned earlier, this issue around implementation. How do we actually get, when we know this evidence works, actually getting it into practice and then ensuring sustained delivery over time? And those are really the key challenges we're working on. I don't have answers to those now, but I know that they're key as part of redefining the workforce and thinking outside of simply health workers and health systems, and then overcoming these implementation challenges that, that I mentioned earlier. And I think that's an exciting and important area and something that we're dedicating a huge amount of efforts to now. And I think it's it's an exciting place to be working given the importance of mental health. So I'll turn it over to Shekhar. I have no more slides, and he'll comment on this as well.
Thank you very much, John, and thanks, Ben, for inviting me and also for your very generous introduction. In the next 3 or 4 minutes, I'll just make a few points and allow me to go back 15 years ago when me and my team in WHO were struggling with the fact that a very large number of countries all along the world have very few psychiatrists, perhaps a psychiatrist, one psychiatrist for 2 or 3 million people and hardly any psychologist. And how do we provide treatment to millions of people who require help? And then we constructed the pyramid that Ben showed in the introduction to this webinar, that really psychiatrists and psychologists are at the top of the pyramid, but there is a lot more other professionals and non-professionals who can actually provide mental health care. And since then, all attempts have been made to really strengthen that part, the middle and the bottom part of the pyramid, and it has worked wonderfully well. The MHGAP program of WHO developed a very large number of instruments, including the MHGAP intervention guide, which really helped more than 100 countries all over the world to provide that kind of assistance so that their health systems now depend on informal community care, formal community care, and care by other health professionals, doctors and nurses, who really help the few professionals to look after only those people who really need it. So there were 2 solutions. One was the pyramidal approach, and the second was, if community has a large problem, just turn it upside down and see whether community also have resources that can provide help to these needs. And those were the 2 key factors which has really helped us to gain a lot of experience. Let's look at some examples of countries which have done this successfully. Look at Sri Lanka, which in the last 15, 16 years has actually trained hundreds of general doctors in providing mental health care. And they link extremely well with a small number of psychiatrists who are there. And these medical officers are trained for about 6 months' time and do a very good job. Take the example of Ethiopia, where doctors as well as nurses have been trained. 650 nurses have been trained who are posted all along the country, and Ethiopia is a large country, and provide immediate help to people who need this help right near where they are. And that has been extremely successful experiment to do that. And my colleague John has already described examples from India, where lay people who have been trained and also peers have been trained to provide the kind of services at the bottom part of that pyramid, which is extremely helpful. So these experiments are no more experiments. These are experiences. And besides the research which John presented, a lot of scaling up is already happening. Let's be careful that we don't call all of that treatment, because the objectives are protection of mental health, promotion of mental health, prevention of mental disorders, and recovery of people who are living with mental disorders. And that is really the key, so that we have the clinical approach by professionals, but we also have the public health approach, which actually links extremely well with the clinical approach. The question is, can this be applied in the US at all? We do believe that when it comes to mental health, all countries are developing countries, and US is not an exception. So we firmly believe that US can be a country which can use some of these experiences extremely well. Are there opportunities? Yes, lots of opportunities. Some of these experiences can be moved with some adaptation directly within the US situations, not only in impoverished settings, but also in the best of the settings, in the most resourceful settings, because even there, 50% people with mental disorders are not receiving any treatment. Are there challenges? Yes. Essentially, there are policy challenges, and we need to have policies which encourage this kind of development and utilize the community resources to care for people who require care and then protect and promote mental health. There could be a challenge because professionals may not like this, and we have seen it in many countries. Sometimes professional organizations and associations protect their own interests more than the interests of the people they profess to serve, and that has to be kept in mind. And one of the keys is not to call it treatment, but to call it care and support, which is absolutely essential. There could also be problems of financing, reimbursements, liability issues, but all of these can be solved if we take some clear policy actions at a local level and also at a state and federal level. And I think this is the time to think of it, when because of COVID, the needs are always there, but they have increased and the resources have actually decreased. So let's hope that we can take that next step on policy and provide the care and support that people need right within the communities by rethinking mental health and by rethinking mental health workforce that we are discussing today. Thank you, and back to you, Ben.
Thank you, Shekhar, and thank you, John. Amazing overview. And there is no better example of rethinking workforce than Priscilla and what Priscilla is about to talk about. Because when we begin to consider a radical departure from just traditional ways of delivery, inevitably we have to come up with solutions to meet people where they are. And Priscilla and some of the work that she's doing, which we're really excited to share with you today, is the living embodiment of innovation on the ground. And so Priscilla, thank you so much for joining us. I'll turn it over to you.
Thank you, Ben, for that introduction. I really appreciate it. And I appreciate being here with everyone. If you can't hear me, please let me know, but I assume you can. So as far as the Confess Project, we are a national grassroots movement that is redefining mental health culture for Black and Brown people. And just to give a little bit of background as far as the work that we've done, we're best known for our Barber Coalition. So in short, what we do is we go into different communities across America that are predominantly Black or Hispanic, and we connect with barbers and we teach them how to be mental health advocates. So essentially we'll teach them, how to speak to people via a trauma-informed approach, how to recognize either verbal or nonverbal cues of someone struggling with mental health. So, such as their speech, like if they say something along the lines of, I'm not feeling well, or I'm struggling, I'm going through it, things like that, our barbers will step in and say, hey, like, do you need to check in? What's going on? And their role is obviously not to replace psychologists or psychiatrists, but rather to be that middle person to connect community members to resources that they otherwise may not have had access to or even have known about. So to date, we've trained about 243 barbers in 19 different cities. And for the rest of this year, 2021, we plan to train at least 557 more. We actually partnered with the public school, the School of Public Health at Harvard. So it's nice to see some people from Harvard today. And according to their study, we've reached approximately 240,000 people each year. So with that trajectory, we should reach about 1 million people in 3 years. And that is remarkable for us because we started as a very small organization in Little Rock, Arkansas, and we've grown exponentially. And I really credit our sense of urgency and passion for helping our communities as the reason that we've really been able to grow. So when we say we're redefining mental health culture, it's important to define, well, what is the mental health culture that we see presently and why do we need to redefine it? So that in itself is a very large topic. You have to discuss white supremacy and systemic racism because to date, we cannot divorce the field of psychology and the field of mental health without talking about those subjects. So just to give a little bit of the landscape, approximately 86% of psychologists are white. And why can that be a little bit of an issue for Black and Brown people? Well, implicit racial bias is a huge issue, and we all have that, including myself. We all have either an implicit, and in some people it's a little bit more explicit, bias towards people that don't look like us. And so even speaking from my own experience, I've had that with therapists that I've seen that don't quite understand generational traumas or don't understand certain symptoms. They might just dismiss it as a stereotypical characteristic, such as Latinas, as myself, are sassy or they're a little fiery. So maybe that's why she's acting that way, as opposed to maybe she has borderline, or maybe she has another condition that needs a little more help and intervention. And additionally, a lot of us have a legitimate fear of white professionals due to historical racism. If you look into the foundation of gynecology, you'll learn that Black women that were enslaved were experimented on. If you look at Guatemala, some of us there were experimented on with syphilis, just as in Tuskegee in America with Black men. So there's legitimate reason that we do have that fear. And if we look at, well, where are the largest mental health facilities in America today? And unfortunately, the top 3 are prisons and jails in Chicago and Los Angeles. And these incarcerated areas are predominantly populated by Black and Brown people, disproportionately, I should say. And in many cases, the first time that some of these inmates receive mental health treatment is behind bars. And to me, all of that is not conducive to our community's healing or to receiving the help that we need. So, I do also want to mention one last thing as far as the background is the school to prison pipeline, as well as the sexual abuse to prison pipeline. It starts at a young age that many of us are kind of placed in these boxes and these trajectories that don't really help us. And as we've seen with Anthony Hill, Miles Hall, Pamela Turner, many of us who call police, well, our family members, during a mental health crisis or for a health check end up being killed by the very people that we're seeking help from. So when you have that background, you realize, well, in order to heal in community or as a community, as someone else mentioned, we need to heal the community first, because if we look at East Baltimore or Boyle Heights in Los Angeles, a lot of these places don't even have adequate nutrition. They have food deserts, they have elevated regulation by law enforcement, whether it's ICE or the DEA. They have elevated rates of crime, elevated rates of not being insured, of poverty, of chronic illness. So when you have all of these factors, it's really almost unfair to expect someone to suddenly have the means to get a babysitter or to find transportation, to find a therapist that will see them on a sliding scale and work with them. So that's where we step in. We can't keep turning the same wheel and expecting a different result. We have to provide innovative approaches to centuries old problems, because when it comes to racial trauma and generational trauma and mental illness, none of this is new for Black and brown people. We've all been, suffering from these things for a long time, but we haven't been getting the help that we need in many cases. And because we rely on an institution, the medical institution, that has been historically racist and predominantly white, it's really not that surprising that we haven't been helped the way that we need to be helped. So I'm really proud of the work that Lorenzo, our founder, has done. He himself is a walking testimony of what can be achieved when you get the right mental health treatment. The reason he's so passionate is because as a child, he suffered from anxiety, he suffered from anger due to many different childhood traumas. He didn't know how to cope with that. And unfortunately, the teachers that he had around him and the adults that he had around him did not provide the help that they should have, either because of they didn't know or for whatever other reason. So once he started to address those issues and he had a second chance at life, essentially, because he escaped a prison sentence, he dedicated his life to helping others that look like him to know that it's okay to get help. It's one thing for someone that looks like myself. I'm Latina, I'm a woman of color, but I still look the way I look. I can't tell a Black man or a Black boy, like, yeah, go ahead, go see a therapist. Everything's gonna be okay, because I haven't walked in their shoes. So it's really important that the people that you serve, you need to have people that look like them, ideally leading or at least upper management that can provide well-informed, people that have actually lived it to say what people are experiencing. So aside from Lorenzo, we have Darnell, who he leads the activities during our mental health trainings. And so even in Philadelphia recently, because we're on a tour right now, going to different cities and doing trainings, one of the attendees, a man that maybe greater society will see as kind of the poster child of a poster man for a very masculine, intimidating man. And he broke down. He just let it all out. He just publicly expressed pain that I highly doubt he's expressed publicly before, let alone in front of a group of strangers, of other men, but other men that look like him and other men that can relate. And in a training session led by a man that looks like him and that has also been through significant trauma. And then as far as myself, I really loved, Kelly's testimony and her speaking about her mental health, because I can speak to why it's so hard for marginalized communities to get help. Often it comes from our own communities, our own families. And I myself live with OCD, borderline, PTSD. I'm in recovery for alcohol abuse and an eating disorder. So growing up, aside from my immediate family, if you talk to my relatives or people from my community about mental health, they really have a problem with it, at least in my experience, that it's actually an insult to tell someone that you're concerned about their mental health or that they might benefit from seeing a therapist. It's often met with hostility or being dismissed, you need to go pray, you need to not air our laundry out to strangers and things of that nature. So as someone who lives with mental illness and has a full-time job and, volunteers and has a life, it's a lot to manage. I actually consider having mental illness as a part-time job. And if I'm really struggling, it's more like a full-time job. And if I'm doing okay, it's like a consulting side job. But I'm always employed by my mental illness. It's always here. It's always going to be here. It's just a matter of managing it. So my takeaway for this, if I had to narrow it down, is just when it comes to Black and Brown communities, you have to take a unique and innovative approach. You can't treat them as white communities because we do face unique issues and problems. And so we need unique solutions. And those solutions need to be led by people that look like us, or at least informed by people that look like us. So thank you.
That was wonderful, Priscilla. Thank you so much. And again, thank you and Lorenzo for the great leadership that you're offering through Confess. Well, folks, we're at time. I think you've heard today, if we're serious about stemming the tide of mental health and addiction needs, we must begin to think differently about our workforce. Payment and policy should support this new approach. From peer supports to barbershops, we have an opportunity to think more creatively about our solutions. So thank you for joining us today. We look forward to seeing you all next week for our session on mental health and primary integration. Until then, be well.